Welcome to the Be Well Collective, a refreshingly grounded podcast dedicated to separating health fact from fiction, offering listeners access to credible, science-based conversations on a wide array of health topics. Each episode features discussions led by medical professionals and experts, providing listeners with the evidence-based insights to navigate the often confusing world of health and wellness with confidence and clarity. Now let's nourish our minds and get into it. All right. Well, hey, we are excited to be here. I'm Sara Hillring, a sport and clinical registered dietitian, and I'm joined by my colleague and favorite co-host, Riley Speth. How's it hanging, lady?
What's good. Up? Yeah, it's good.
Yeah. You having a good week?
Yeah. Busy, but good.
Busy, but good.
Yeah.
It's the usual around here. Yeah. Busy, but good. Well, right on. Today, we will be diving into the topic of borderline personality disorder, BPD for short, a diagnosis that comes up quite often, but is regularly misunderstood and carries stigma. Listeners, you might have heard the term thrown around before or even portrayed in the media, but there's so much more at play than the stereotypes we see or hear.
Yeah, so with that said, let's dive in. I want to first kind of introduce what borderline is, maybe talk about the history, criteria for it, looking at genders and causes. Borderline personality disorder, also known as BPD, is defined as a pervasive pattern of instability in interpersonal relationships, self-image, and affects, and marked impulsivity, beginning by early adulthood and present in a variety of contexts. So in simple terms, borderline personality disorder is a mental health condition where people often struggle with intense emotions, unstable relationships, and might have a shaky sense of self with who they are. They might act impulsively, fear being abandoned, and sometimes feel empty or angry without really knowing why. So these patterns usually start in early adulthood and show up in different areas of life. So where does the term borderline come from? The term borderline was first introduced in 1938 by psychoanalyst Adolf Stern. He described patients exhibiting symptoms that seemed to lie kind of on the border of diagnosis. He found that patients didn't quite fit the mold of diagnosis that we knew of then, which was coming from either a lens of neurosis, so no break in reality and thinking of diagnosis, such as anxiety or depression, or psychosis, which is a break from reality. That includes delusions and hallucinations. BPD was developed as this kind of middle ground because individuals exhibited emotional instability, disturbed relationships, and identity issues, but didn't really show the full-blown symptoms of schizophrenia, which is a psychotic disorder, or the more controlled symptoms of neurosis, such as anxiety or depression. Borderline personality disorder was first introduced in the DSM-3 in 1980. So when we break it down, there are 9 diagnostic criteria. And for someone to be diagnosed with BPD, they need to meet 5 of these 9 criteria. So if you're coming in for therapy and you're interested in getting a diagnosis of BPD, therapist will diagnose you on a self-report from client and by observing behaviors. So again, to meet criteria, you need to exhibit 5 or more of the 9 symptoms. It's not necessarily passing behaviors, but something that's really consistent in your behavior over the lifespan. So let's break down the 9 different criteria. Number 1, frantic efforts to avoid real or imagined abandonment. Number 2, very intense or unstable relationships. Number 3, identity disturbance, not really feeling sure about who they are. Number 4, risky or impulsive behaviors. This could include excessive spending, sexual behaviors, substance use, binge eating, etc. Number 5, recurrent thoughts or behaviors related to self-harm or even suicidal acts or behaviors. Number 6, big mood swings or variability that lasts usually a few hours or could rarely last up to days. Number 7, feeling empty inside. Number 8, trouble controlling anger or difficulty with inappropriate anger. Number 9, feeling paranoid or disconnected from reality when stressed. Borderline personality disorder is the most common personality disorder, affecting around 1.8 of the general population. It's actually the most commonly diagnosed personality disorder. So when looking at men versus women, women are more likely to be diagnosed with BPD. It's about a 75% breakdown of people diagnosed. With it are women, so about a 3-to-1 ratio of women being diagnosed compared to men. We don't really know why that is. Some things to consider is that women could be more likely or are more likely to access treatment, or there could be even a gender bias at play when it comes to diagnosis. Men with BPD can commonly be misdiagnosed with PTSD or depression. All right, so what causes borderline personality? Where does it come from? It's not super clear-cut, but researchers agree that it could be a mix of factors. Could be genetics that are playing a role. So if someone in your family has BPD, your chances go up. There's also an environmental component. Things like childhood trauma, neglect, separation from caregivers can increase your risk. And finally, brain function seems to be a part of it too. Studies show that parts of the brain that handle emotions and decision-making might not be communicating smoothly, which can help explain some of the intense emotions and experiences people go through with BPD. All right, lastly, diagnosis. Let's talk about that a bit. As a clinician, something that I'm looking for and mindful of when I'm working with someone with BPD or any personality disorder really is I'm looking at their treatment history and if they've been resistant to treatment before or if other things that they've tried just really haven't worked for them. It's pretty likely that someone could have a co-occurring disorder, meaning they have maybe like depression and BPD or PTSD or, one of the variety of diagnoses. In my clinical opinion, BPD is something that needs to be tailored care for the individual. So one of the most common treatments out there for BPD is called DBT, known as dialectical behavioral therapy. However, it's not the only treatment out there for it. Our guest today, Misty, we're bringing her in because she has a kind of a different aspect and way to approach borderline personality disorder, and it's one of her specialties. So I'm super stoked for Misty to be here and looking forward to this conversation.
Yeah, absolutely. Well, really well defined, Riley. Thanks for outlining that. I'm really excited to dig into this. This is such a curious area for me. I don't work a lot with patients that experience BPD in my practice, so I'm excited to dive on in. So without further ado, today on the pod, we have our lovely guest, Misty Newman, who is a clinical mental health counselor and has been practicing since 2013. She has a bachelor's of science in sociology with a focus in criminology from the University of Utah and a master's of science degree in mental health counseling from Westminster College, which is now known as Westminster University, which is also located in Salt Lake City, Utah, in the States. Misty owns Mountain Valley Counseling, an outpatient group practice in South Jordan, Utah, that focuses on complex trauma and treats people across the lifespan. Misty also works with adults in individual therapy. She has extensive experience working with complex post-traumatic stress disorder, so we often say this shortened as PTSD, personality disorders, substance use issues, depression, anxiety, postpartum related difficulties, religious transitions, religious traumas, grief, existential crisis. Aside from her clinical work, she offers supervision, consultation, and teaching services. She offers training and teaching on psychodynamic therapy, as well as cluster B personality disorders. Welcome, Misty. Wow, you do so much. This is so cool. I'm very excited. It's an absolute pleasure to have you here today. I'm so intrigued, and I'm really looking forward to learning from you today. So thank you so much for being here.
Thanks for having me. I'm excited to be here. Excited and a little nervous, and that was a great introduction.
It's okay to be nervous. That's welcomed. All emotions are welcomed on this podcast. So we love the transparency. I think we're always a little nervous too, because we care. We want to do well.
I'm always nervous.
There's
not a day that I'm not nervous on this podcast.
I'm always excited. So it's a good balance of energy, I think. Absolutely. Well, thanks for being here. We do, of course, most importantly love to introduce you. And then we always love to start off in a way that just kind of sets the tone, kind of calms the nerves, hopefully, Misty and Riley, and just helps us settle in. So we kick off each episode just in a bit of lighthearted fun. And we ask each of our guests and each other what our favorite snack is or what you brought to the podcast as well today too. So Misty, you're the guest of honor. Do you care to start us off? What did you bring to snack on today's pod?
It's really boring, but good. It's a chicken burrito bowl from Costco. It's my lunch. I love it. But my favorite snack would probably be like any carbohydrate, any bread.
Any bread.
Or like toast.
Toast. Yes. Yes. Do you put anything on the toast? Like, do you have toppings? What's the situation there?
Sometimes I put peanut butter, but I also just like butter. Just plain old toast. I like sourdough bread, any kind of yummy bread.
Oh, tried and true. I love it. A classic. Sourdough always hits.
Mm-hmm.
It's so good. Okay, lovely. I mean, I have a snack, but that's making me hungry. What about you, Riley?
I brought, let's see. It's called a caramilk. So this I've been saving in my desk for a little bit for when I need a sweet treat, because I always need a sweet treat in my desk.
Of course.
One of our coworkers went to Canada and brought back a bunch of candy.
Oh.
So it's a Cadbury, but I'm excited to try it.
Oh,
so, yeah.
Fun.
Yeah, so that's my snack, my sweet treat afternoon snack.
Everyone needs one. Love it. That's
What
awesome.
did you bring?
I'm currently de-thawing a smoothie right now. It's in the works. Yeah, so it's not drinkable at this time, but it's great. I love it for like a recovery smoothie. So if I'm doing something active and fun outdoors, it's a nice way to recover. It's got all the good bits, the carbs, protein, lovely dietary fats, all the fun flavor. So it's just a good blend of kefir, berries, Greek yogurt, collagen, all the good stuff.
Sweet.
Yeah.
Well, should we switch gears and get started?
Yeah.
Okay.
Let's go for it.
Perfect. Well, Misty, I'm really curious. How did you get started? I don't know this.
Yes. Well, I don't know how far you want me to go back, but I graduated from Westminster in 2013. And then I was working in a community mental health clinic. I did my practicum and internship there, and then I got hired on VOA, Volunteers of America Cornerstone Counseling Center. It's an awesome treatment center, so I want to give them a shout out. What we did there, and I believe what they still do, is I was on the substance abuse treatment team, and I worked with people that had like severe persistent mental illness. They were often court mandated to treatment. A lot of them were homeless clients, and they had substance use problems. And so on the surface, as a student and a new clinician, you'd think, just like on paper, all you're working with is substance use. That was just a symptom of deeper issues. I quickly learned that. And the treatment team I worked on and my supervisors were so great at like sort of garnering learning around that and helping me understand, and all of us, the clinical team, that we were trauma therapists. That was really our specialty. And substance use was a symptom of that difficulty. Also, what I found, it just sort of fell into my lap. I started working a lot with clients that had substance use issues and all the things I mentioned before, but also had, this is DSM-4 language, access to diagnoses, which were personality disorders, cluster B personality disorders specifically. There are cluster A and cluster C, but I worked a lot with cluster B, and that's become sort of a specialty of mine. So it just sort of fell into my lap. And the treatment team would often say or tell me I found myself to be pretty skilled and talented with folks with borderline or narcissism or antisocial personality. It just happenstance. And I would get lots of referrals at the clinic. Oh, Misty, you should see this person. You're good at this. So that's kind of how I found my way doing my own personal therapy and work. I think I'm good at that and pretty intuitive with someone with a personality disorder because I have some people in my personal life that struggle. I know that now and they know that now, but as a kid and just like growing up, we didn't know, So yeah, I think I can just sort of see intuitively, feel into what's going on. And I was able to help and conduct myself in such a way in my family system growing up without any book smart or psychology skills that I later got in my master's degree, how to support people with personality disorders, and also a history, I can't emphasize enough, of untreated trauma. My lens, and I think a lot of research shows that people with cluster B personality disorders specifically have, generally, it's an adaptation and have untreated traumas. So from childhood, or mostly from childhood, I would say is what I see, but also throughout life.
Yeah. So it sounds like it was one of those things that you didn't necessarily know that you were going in to like be a specialist, right? It was something that you kind of just found that you were good at.
Mm-hmm. Yes. And then I enjoy the work and I've got confident in it and more training. And I've been doing this since 2013, so 12 years. And yeah, it's slowly but surely became something I specialize in. But I always like to say and start with, like, my main specialty is trauma, and personality disorders it would probably be like a secondary specialty. But I used to see a lot of cases with personality disorders with different levels of acuity, sometimes more severe acuity, some suicidal ideations and attempts and self-harming behaviors. And now that I own my group practice, I do a lot of supervising of interns and newer clinicians. And so I don't do as much clinical work as I used to. I still do some though. And I still work with clients that have cluster B personality disorders.
Yeah, Misty is a rock star. I'm actually a part-time therapist at her practice. I was just a baby therapist graduating from grad school, and Misty took a chance on me, and I've worked with her ever since. So she's amazing and one of my mentors and someone that has really fostered a lot of my growth as a clinician. So really grateful that you're here and grateful to have this conversation. Misty, I'm really curious, and for listeners, I think that we throw around, like how I mentioned, like DBT is kind of the therapy that's often used with borderline personality disorder, but it's not the only treatment. So I guess I'm curious, can you speak more of like, what is your theoretical framework? Like, what do you use? And kind of what does that, just could you break it down for us and kind of tell us what that looks like a little bit more?
Yes, dialectical behavior therapy, I have to say, is awesome. It's awesome, and it's really commonly known. And sometimes words like, or phrases like evidence-based or gold standard are thrown around in association with DBT or any kind of cognitive behavioral therapy. So I do use DBT when the treatment calls for it. I pull from it. And I am trained as a psychodynamic therapist. And I also work from an attachment theory perspective, and I use object relations and transference focused therapy specifically. Those are all under the umbrella of psychodynamic therapies. Psychodynamic therapies are kind of old school. Not a lot of people on the West Coast are familiar with them or trained in that way. They're much more popular on the East Coast. I don't really know why, but Westminster University locally is really great at exposing clinicians to the modalities. I get a little bit on a soapbox here. Sometimes they're criticized for not being evidence-based or the gold standard, and that is false. They're just harder to measure and study because CBT or other treatments that are more manualized, they're just easier to study in research, right? It's like, oh, they did this, they implemented this behavior, and we saw them for 12 weeks, and they took this assessment tool, pre-treatment, post-treatment, and clearly there's this statistical significant difference in symptom reduction. Psychodynamic therapy is much more abstract and focuses on depth work, and you can be in therapy for a long time. I think, not to get too in the weeds with this, but psychodynamic therapy focuses a lot on your foundation that's built in life and really looks at your childhood experiences, your attachment style based on early childhood experiences. So that could be, you could have a secure attachment or an insecure attachment style. And there's some subcategories of that: anxious, avoidant, or disorganized. And someone with borderline personality disorder could have any of the three insecure attachment styles. And so psychodynamic therapy really is looking at how early childhood experiences and complex traumas have affected the person and the psyche and are manifesting today in the treatment. And transference focused psychotherapy would focus on what's happening between the client and the therapist in the relationship, in the interpersonal process, in the space between them, and makes use of that therapeutically to help someone understand why they might be having problematic behaviors as a result of their personality disorder outside of the therapy hour. And then, if you're focusing a fair amount on attachment theory, which I do, you're really trying to create a secure attachment between the therapist and the client in that dyad to provide a corrective emotional experience if the person has an insecure attachment style, which generally speaking, and in any case I've treated, one does have that when they present to therapy with a personality disorder, cluster B specifically. And I don't think I'd be hard pressed to come up with a person that I've treated and seen that didn't also have complex trauma. That is the way I practice. There's also a fair amount of research out there that does demonstrate longer term therapy as being beneficial for someone with a personality disorder. It just takes time, right? To sort of understand oneself, the impacts on their childhood or their traumas, and maybe learn new skills and new ways of relating to oneself and another person, and to develop a secure attachment to a therapist. That takes some time where we can really do some solid work. I would also say with object relations and DBT, there's some similar concepts. People with personality disorders, I would say all people do this, but sometimes people with personality disorders do this a little bit more, where they have a hard time finding the gray or the middle in things, can be black and white thinkers. That's dialectical behavior therapy language. Object relations therapy would say they have a hard time whole object relating. They see things in parts, sort of, right? Like all good or all bad, themselves and other people included in that.
So we were talking about attachment styles in relation to BPD, and what that brought to mind for me out of curiosity, is there an attachment style that is more predominant for that individual?
I would say people, generally speaking, with a personality disorder, a cluster B personality disorder, present to therapy with an insecure attachment style. And there's 2 or 3 subcategories of that. There's anxious, avoidant, and disorganized. And I can go into what those look like if you like.
I would love that.
Sure. Yeah.
Let's go into it.
Yeah. So someone with an anxious attachment style, and sometimes the literature calls this preoccupied, but anxious attachment would be someone that, like, maybe their caregivers were there and reliable some of the time, but not always. And so consistency and safety was uncertain, right? And you just didn't know, like, if you were coming or going, or if you were going to for sure have that or not. And so people can grow up expecting that in relationships from others. Just there's a fair amount of anxiety that will manifest itself in interpersonal dynamics, which can look just like generalized anxiety disorder. And they might fit criteria for generalized anxiety disorder, but they also have maybe an anxious attachment style, right? Just feel unsure in relationships, but want relationships and keep trying in relationships. Someone with an avoidant attachment style, like, they could have a similar upbringing as someone with an anxious one, but I would say the deprivation is probably more severe. Sometimes these are like households that on the outside looking in, they look fine, but maybe there's not like a lot of emotional support or talking. Like, nobody knows how to do that. Parents don't know how. And so it's just kind of cold or emotionally barren, or everyone's just kind of on their own. Like you're just on your own. You know that. You've known that since you were little. And so you really have rejected the idea that people can be there for you. And so a lot happens when you're in an interpersonal relationship with someone that's close, trying to be close or intimate. A lot of anxiety or fear will come up, but that just presents itself as almost like rejecting. Like someone with an avoidant attachment style would just be like aloof. Like, I don't, you're the one with all the need, not me. But there's a lot of anxiety underneath that actually, but it's almost like they're not aware of it. And then disorganized is kind of like a combination of anxious and avoidant on steroids. So there's like kind of a push and pull in relationships, right? Like I'm anxious. I really want relationships and attachment. And I'm nervous you're not going to be there for me. Ooh, and I'm also going to push people away and try to not need them and try to be independent and on my own. And then just kind of a back and forth with the two. And I should say in that sort of dynamic or household, generally a disorganized attachment style, generally there's a fair amount of trauma and abuse that goes on that makes relationships super confusing. It's like sometimes maybe there's kind of there for me and I want that connection. And then other times they're not, and I'm on my own and I'd rather be on my own. But wait, sometimes I want connection. So that was a real reduced version of explaining attachment styles. There's a ton of information out there and literature on that.
Yeah, I think that that's so interesting that we aren't necessarily going to have one specific attachment style with borderline personality disorder. I mean, there are some that maybe are a little bit more common, but shouldn't be pigeonholed in one specific area of your life. So this is a great pivot to talking a little bit more about the myths surrounding BPD, and oftentimes why they're not just wrong, but can be super harmful. So some of the myths surrounding borderline personality disorder are people with BPD are always manipulative.
I hate that one.
Yeah. So always manipulative. BPD cannot be treated. So it's kind of untreatable, something that you'll have forever and ever. Mm-hmm. People with BPD are just attention seeking. And lastly, people with BPD cannot have healthy relationships. Misty, I'm just curious, hearing those, what thoughts come up for you regarding some of these common misconceptions that people have regarding BPD?
Yeah, well, I have a reaction to them every time I hear them, just because I have found the contrary to be true in my treatment with clients. So I will say, I think sometimes when you're in a relationship with someone, hearkening back to the attachment styles, when you're in a relationship with someone that has an anxious or an avoidant or a disorganized attachment, you're on the receiving end, you can feel kind of moved around and it can be really confusing and emotionally taxing. And so because of that, I think there's a lot of stigma with the diagnoses and a lot of assumptions made and misunderstanding, which is probably why there's like those judgments, right? This used to not be a very well researched or studied area, but I would say in the last decade or so, or probably since I graduated, it's getting way better and less stigmatized in the field. But a lot of therapists they're not that well versed in treating it. And so sometimes I've seen many people come to me with diagnoses like bipolar disorder or other diagnoses that just don't fit. There's probably like a PTSD diagnosis or a borderline diagnosis at play. I disagree with the fact that they can't be treated. That's an old myth from, I think, the field of psychology, that once you have this, you're always going to have it. I have someone right now that I'm treating, and I've been treating for over about 5 years, that most days probably doesn't meet criteria for BPD any longer. When this person's, attachment system gets activated, or they have an encounter with someone that isn't very supportive or safe, it does kind of take them back. And some of those old behaviors flare up. So it's something I think this person's always going to have to navigate and deal with. But that does not mean that's not the same thing as it's like not treatable and that there isn't success. Because I've seen great success with that person. And that person definitely has healthy relationships. It's just really learning a new way. Like when your attachment system is insecure based on early experiences, sometimes we just don't know how to operate in relationships with people. And so we have to sort of relearn those things and also regulate our emotions, our distress, because fundamentally, like at the root or the core is fear of abandonment and rejection, right? And so there's different ways that sometimes are maladaptive that someone might show up interpersonally in a relationship to try to get their needs met, which is not manipulative. It's just survival. And they need to learn new ways of operating and new ways of coping. And so in the way I do therapy, it's often in the context of the relationship with me, kind of practicing those behaviors. And it's also me noticing with them what they're doing and helping them see what they might be doing when they get triggered, et cetera. Is there another thing to do? Is there something we want to do differently? And even sharing maybe how that impacts me, or if they could think about how that might impact other people in their life, which is sort of a mentalizing approach, kind of taking a bird's eye view of what happens dynamically in the relationship.
Yeah. I think about back to attachment theory, and it really is building that secure base. And that starts first and foremost with your therapist and then usually extends to outside relationships. So just like how you mentioned with borderline and how sometimes we can get to a place where we don't necessarily meet criteria, same kind of goes with attachment style. And I think that we can change attachment styles. Misty, I don't know if you feel differently towards that, but I think the whole goal is building a secure attachment.
Yeah, no, I think you can. I think you can work towards getting to a secure place in your life as an adult. Let's say if you present to therapy as an adult and with and finding people in your life that would provide a secure base, right? So sometimes it's learning to pick different people. And maybe we don't have healing with our early relationships. Maybe there's always a insecure attachment style that persists there, but that doesn't mean we can't have a secure attachment style with other relationships. And I would say there can even be healing within a family system, right? If parents or caregivers are willing to take a look at themselves and make amends or repairs, and maybe this would be super great if this happened all the time. But if parents or caregivers were accountable and apologetic and worked on themselves too, if that was previously a source of an insecure attachment, maybe it could move to a secure place.
And Misty, is that a part of your treatment process? If family is amenable to coming in and exploring that, do you do group counseling or supportive work with both that individual client and then as well as those relationships from past?
I think that is a great idea and a great point. And I would say when I worked at community mental health clinic, sometimes, family was involved for sure, for better or for worse. Sometimes it wasn't very effective or helpful, but sometimes it was healing and helpful. And I think we would definitely do that here at Mountain Valley Counseling.
Yeah, absolutely. Probably depends on the setting and access, of course, to where you live, where family is, and an interest in doing that work and doing that healing. And I'm sure it can go very much either way. It can be very constructive or go a little bit south. That brings me back to reflecting on what you were saying about when you're working with a client and you take that bird's eye view approach. Does that elicit for a lot of clients a different headspace to be in, or does that reframes it when you're speaking about how like that's impacting you as the provider-patient relationship?
Yes. Yes to everything you said. It's like I would say it's like a therapeutic intervention or tool I use, but at very appropriate times. And so I think I would need to have be on my way or have arrived at a secure place with a lot of trust with the client before making an interpretation like that, because I would want them to be able to take it in, right? And a lot of the times people with BPD, part of their trauma is they've been really invalidated. and not felt seen or heard or understood. And so a lot of the work throughout, but especially in the beginning, is showing and demonstrating that I want to understand. I want to be supportive. I want to be a safe place. Like, help me understand, and being validating. And so you want to do a lot of groundwork there before sort of handing to someone or helping them look at other people's perspectives, because that might be offensive if that's handed to someone too soon. We really want to see the client's perspective first, right? Someone needs empathy to be able to extend empathy to others. And that's kind of what I'm trying to do, take the perspective of another down the road. So I guess it's kind of more of an advanced intervention, but it's a really useful one.
Mm-hmm. Absolutely.
Misty, are there evidence-based recommendations for treatment, or what does the evidence say regarding like best treatment out there?
Yeah. So I can speak to BPD. Group therapy is a super effective modality for personality disorders. And that's because the group and the therapist present, they're both kind of like the therapeutic intervention and tool. Like a famous therapist says that the group therapy is the recapitulation of the primary family group. And so people can kind of work through past difficulties in the here and now in the group. And sometimes different group members will represent or bring up feelings about people from their past. So group therapy is awesome. Medication management is an intervention people always go to, and it doesn't cure or treat personality disorders, I'll say that. However, meds can really help sort of take the edge off some of the symptoms associated with borderline personality or NPD and whatnot. And sometimes depression, anxiety, things like that can accompany those. And so the meds can really help that. I talked about psychodynamic therapy, and within that, transference-focused psychotherapy. Transference-focused psychotherapy is just about as effective as dialectical behavior therapy. And that's, the founder is Otto Kernberg of transference-focused psychotherapy. And what you're doing is you're focusing on the relationship and the transference space. These are real therapy words, but between the client and the therapist, what's coming up in this space, what the client is feeling. How did they just hear what the therapist just said? Does that remind them of anything, et cetera, et cetera, et cetera. And then DBT is awesome because the creator of DBT, Marsha Lanahan, she's so great, and she actually has BPD herself. And she developed all these really great, wonderful skills and tools, kind of concrete things people can hold on to help regulate affect, help interpersonal effectiveness, get in tune with oneself and emotions. It's really great for actually many things, but really effective for BPD. CBT can be helpful too.
A lot of great modalities to support and to use a part of the process. I'm curious, Misty, I know you're in the private practice space. Do you have the opportunity to collaborate as a part of the treatment process with other health professionals? Do you ever work with dietitians like myself or anyone else and collaborate together to support someone's care journey?
Yes, absolutely. A common occurrence with BPD is co-occurring disorders, right? Not just PTSD. I sort of see it all as PTSD or complex trauma, and everything is like a symptom of that's just not being treated. But a lot of times people have eating disorders, for example, or self-harming behaviors, or substance use issues, or some impulsivity, sort of high-risk, dangerous sexual behaviors or spending behaviors. And those are usually just symptoms of trying to regulate oneself, trying to cope with feeling distressed, having heightened emotions, fearing abandonment, etc. And so, yes, I have seen clients with both and more things. And sometimes it's really indicative that we need to get the substance problem or the eating problem under control for us to be able to work on the personality stuff and the trauma. And so sometimes we refer people to the Center for Change is a really great place. And then always invite people back.
Mm-hmm. It's a lot of important collaborative work because there is a lot of co-occurrence. I work with a lot of eating disorder cases. So I definitely in my practice will probably run into a time where I will have a patient where there might be that co-occurrence, right, of BPD. And so I always love looking into the research and the literature on that just to make sure I'm well-versed, I am ready if that comes about. And then I always have great resources like you mentioned, and then lucky to have a mental health therapist right across the way where we work. And so when it comes to the nutritional space, I always like to make sure that any patients know that it is not curative, right? Diet is not going to be like the cure-all. It's not going to solve the issue, but it's a collaborative approach. It's a piece of the puzzle, just like therapy, just like medication management, if that's a part of your process. That's such the beauty of having this well-rounded team or the ability to collaborate. And so if you don't mind, I might just jump into a few 3 key things for nutrition that might be constructive. So if anyone has BPD, hasn't had the chance to interact with a dietitian before, they don't have access, maybe just a good place to start.
Yeah.
Okay, I'm going to go for it then. That being said, this is a piece of the puzzle, so not the sole thing to rely on. However, nutrition is, of course, like all sciences, we're growing, we're learning, we're expanding. So the research is still developing in the space of BPD, but primarily we want to look at a threefold approach when it comes to BPD from a nutritional lens. We have omega-3 fatty acids, and those within the research context, some interesting overlap with impulsivity and affective dysregulation. So being able to play a role in seeing reduction within that. When I think of omega-3s, I usually like to throw out an example because not everyone knows where those are, what they're in. We have someone shaking their head back here. No. So that's things like salmon, tuna, sardines, seaweed. Those are key dietary sources. So making sure that that's incorporated within someone's diet could be really constructive. And then the second I think about is magnesium. Riley, do you use magnesium? Does anyone use magnesium on this call?
Yes.
I don't.
Misty does? Oh.
Yes. I do.
Okay. Yes. Very cool. Do you mind if I ask? Do you use capsule, powder from food sources?
Capsule. And I use the one, I know there's a difference between magnesium citrate and something. I try to use the one that helps you relax and sleep.
Yes. Magnesium bisglycinate is what it's called. So usually that would be the form that we would use. Magnesium citrate can be effective for different reasons. Usually we want to use that if we need a laxative effect. Most people are not looking for that before they're trying to go to bed. And a lot of people like to use magnesium bisglycinate alternatively because it's supposed to help us relax and simmer and feel hopefully just more balanced before we go to sleep. And so that would be certainly something that might be considerable to supplement with for a patient or a client with BPD. I typically like to explore food first if possible with the individual depending on means and financial resources. But when we think about magnesium, I think it's so cool, the micronutrient, because it helps neurotransmitter support. So you think about GABA specifically, and you think about glutamate. And so it dampens the excitatory neurotransmitters like glutamate, and it helps balance neurotransmitters like GABA. And that plays that role in feeling calm and feeling relaxed. So that's a little bit of the nitty-gritty science behind it. And it also plays a role in controlling the release of hormones like cortisol. And then also supports proper conduction of nerve signals. So if we have low serum levels of magnesium, which looking at research, individuals with BPD tend to trend lower in their serum magnesium levels. So that's kind of curious. So you think about all the things magnesium does. So if we're experiencing BPD and we're looking for magnesium sources, there's always supplementation. And I always recommend working with your provider or a dietitian on that. But pumpkin seeds, chia seeds, almonds, cashews, those are going to have the highest amount of milligram per serving compared to all other dietary sources. So that might be constructive for someone that is looking to add that into their diet because it plays such an important role. So that's my hot take on magnesium. It's not a hot take, it's researched, but I think it's important to know that it does play a role with our neurotransmitters, with how we feel, our anxiousness levels, our calmness, our hormones. And then our third one is vitamin D. Definitely a big one here. We live at a certain latitude where we have a lot of winter months. We are covered up a lot of the year. Where we primarily synthesize vitamin D is from the sun. And if you're covered up, you're not doing that very well. A lot of us spend a lot of time indoors, perhaps during peak daylight hours, like we are right now. We're not synthesizing vitamin D right now. And so that's another one that has been shown more on the aspect of individuals displaying suicidal ideation, lower levels of that nutrient. When we do a panel, there tends to be a correlation, at least. And I know that that can be a key feature of BPD. So just making sure that that is an optimal focus in the diet. Vitamin D is a little bit harder to come by in the nutrition landscape. We are lucky here in Utah. We've got a lot of rainbow trout. So if you have access to that, it's really high in vitamin D. Salmon is a dual benefit. You get some nice omega-3s and vitamin D from it. So that's pretty cool. Your other fatty fishes, dairy products that have been fortified. But I think that's an area to really think about as well, too, is these key 3 nutrients can do a lot for the body. They're not going to resolve, but when we use it in collaboration with wonderful practitioners like yourself, we can see some changes in serum levels and symptomology, and then how that impacts behavior or anxiety levels or feelings that elicit. So that's my quick nutrition segment for you, but I just find that super fascinating and how it intertwines.
That's great.
Mm-hmm. I love collaborative care. I love being able to hear about both of your domains and hear about how nutrition's not really something I've ever thought about as far as treating borderline personality disorder. I mean, of course, it plays a factor into it, but that's just something that's so far removed from my training and skill set. So it's always team collaborative care.
It's valuable, right?
Yes.
Yeah, it's super important.
Well, Misty, I guess I'm curious for you, how does it feel working with someone with a diagnosis of borderline personality disorder? And are there obstacles that you see or face as a clinician?
Yes. So even though I have a lot of experience with it and I've been doing it exposed to working with this population for many years, I still get anxious. I still get nervous when I start working with someone that comes in with this diagnosis. And I would say that's because I worry. I'm trying to assess for their level of acuity and if they are suicidal or not, and if that a means of coping with emotional dysregulation. That's always something that, it's just heavy to hold as a clinician. You never want someone to commit suicide or attempt suicide when you're treating them. You want, I didn't get into this to not help people. I want to feel effective. And so that's always an obstacle and something that's sort of heavy to carry. And not everybody is actively suicidal or even attempts, right? Or has to be hospitalized. But sometimes more acute cases do present with that symptom. That would be an obstacle. And also, as I said before, sometimes being in a relationship with someone that has borderline personality disorder, you can feel kind of moved around by them. And that's just to sort of piggyback on how I was talking about working with someone that's suicidal. You can just hold a lot of worry and concern. And so you have to do I found a lot of self-care and really figure out how many acute cases I can treat at one time.
Yeah, beautifully said. I think that's something that I've learned to keep in mind of how am I being moved around in the space and what does that mean with the work that I'm doing with clients? Because it can feel really dysregulating in therapy.
I will say sometimes as a therapist, you'll feel what your clients feel. right? And so what Riley was saying, you said something that just made me think that. So I was just piggybacking on that. But the feeling moved around a bit, or feeling worried or dysregulated yourself, that can just be a product of what the client or patient is bringing in.
Mm-hmm. Mm-hmm. I like to think of it often as we're the kind of stability. They're trying to like move us around maybe, but we're a piece of stability in their life.
Mm-hmm.
Mm-hmm. Absolutely. I'm curious with that, Misty, if you have any advice on what is the best practice to supporting someone that has a BPD diagnosis. So whether I'm a family member or I'm a practitioner, a non-mental health practitioner, I should say, how do I effectively engage with that patient to ensure that our sessions are productive for them, that it's non-triggering in that sense too, that also you can find more of that core and not feel like you're being moved around?
I would say, when in doubt, number one, validate.
Yeah.
Validation and helping someone feel seen and understood goes a really long way. With that, also, I would say boundaries are super important for everyone to implement and learn. They keep the client safe, and they also keep the treating provider or family member or friend safe. And so when I have someone that might engage in suicidal attempts, threats, etc., and talk about that with me, I take that very seriously, and I let my client know that. So I don't kind of engage in dancing around that topic. I just call it out and act and tell them what I will do. So, okay, if that's the space that you're in, we're not going to hem-ha or just like talk around it. Do we need to call the police? Like, what do we need to do? Do you need to go to the hospital right now? Let's do that. So that is one way to implement a boundary. And I think people can do that too, right? Like if someone's afraid that someone in their life is suicidal, or they're saying that or threatening that, act. Call the police to go do a well check on that person. That is a boundary. It's when you say this, whether you're serious or not, I'm serious. This is what I'm going to do because I don't want you to do that. I care, right? That would be one example of a boundary. And so do you guys have any other questions or thoughts about that?
No, I think that could extend both to, as a clinician, Sara and her practice, or us as mental health providers, but also family members. I love that piece of holding both compassion, but also being boundaried for an individual, validating their experience and being compassionate, and also super boundaried and not tiptoeing around certain situations or experiences. Yeah, and holding those boundaries, I think, are really effective. So yeah, thanks for sharing that. So we've already touched on this more, but Misty, let's just hone it back in full circle. Do we forever have a BPD diagnosis?
I would say no, or not always. I would say people can go into remission, but it's like a pathway in the brain, or pathways in the brain that could always be accessed again in times of stress, right? So lots of healing and recovery can happen, but sometimes when we are re-traumatized or we're in a stressful situation, some of those old patterns of thinking and behaving can get activated.
Yeah. Beautifully said. I mean, as I guess I'm thinking of, there's probably a broad variability in listeners. And Misty, is there a piece of advice, if I'm someone listening that's maybe thinking this could be a fitting diagnosis for me or a family member, not quite sure if I should, how to go about it or what I should do. Is there any advice or anything that comes up for you that you would give audience members?
Yeah, I think, gosh, as a mental health professional, I'm a proponent for therapy, obviously. And so I think encouraging loved ones, yourself, to get into therapy and maybe find someone. On Psychology Today, you can research therapists. You can kind of like look for people that take your insurance or in your area, see what their specialties are. You could look for some of the treatments I've mentioned, someone that knows about I would say trauma and BPD would be useful and effective for someone that thinks they might have BPD and wants to explore that, or thinks they have a family member. You could help them find a therapist, or you can also go too and get some support, because being in relationship with or loving someone with this diagnosis can be challenging too on the other side.
Absolutely. My last question for you, Misty, I'm sure I have so many more after I process all the great information you've provided us today, is a different type of practitioner, not a mental health practitioner. But even if we have anyone that's a listener that is a mental health practitioner and wants maybe more training or more education on BPD, do you know of any good resources, whether it's groups or, research or books or anything that you can think of that might be constructive to jump into or seek out?
Gosh, yes. Okay. So if you're a mental health practitioner, I would say if you're kind of starting from ground zero and you don't have a lot of experience with this, I think any sort of training in DBT is really, really effective. I also think if you're interested in psychodynamic therapies, the way I practice, there's a really great institute, a national chapter. It's called the International Psychoanalytic Association. And they've got some great trainings. They're usually via Zoom because most of them take place, I think, back east. There's some great podcasts out there. There's a podcast called, let me pull it up here. It's David Pewter's podcast called the Psychiatry and Psychotherapy Podcast. It's such a useful podcast. He talks about lots of things, but personality structure comes up often. Those would be the places I would start.
Yeah. Misty, can I jump in?
Yeah, really,
yes.
Go for it.
One book that comes to mind is I Hate You, Don't Leave Me. Have you read that, or are you familiar with that, Misty?
I'm familiar with it. I have a close loved one that read that book and found it really helpful for them. They're not a clinician, for understanding a family member that struggles with this. So I've not read it myself, but I've recommended it and heard about that book many times.
Yeah, so that might be a good book to look at if you don't have much background or knowledge and you're not coming from a clinical or professional sense, because it does really kind of break down a little bit more. It does more of a deep dive than we did here today.
Those are great recommendations. Thank you so much. That's really helpful. We appreciate it.
Misty, where can listeners find you or kind of follow your work and the work that you're doing at Mountain Valley Counseling?
Oh, yeah. We have a social media presence. You could be one of our fourth follower, just Mountain Valley Counseling. Or we have a website. You could find us there. And if you're looking for mental health treatment or support, you can schedule an appointment to talk to one of our intake coordinators and get scheduled. But our website, you could just Google Mountain Valley Counseling, South Jordan, Utah, and our website will come up. But it's www.mvccutah.com.
Perfect. Thank you. We can always put those in the show notes so people can access and know that there's a really great resource down south. So thank you.
Okay, well, that's it for borderline personality disorder. And by that, that's it. That's never it. There's a lot more that we could always talk about. But for our conversation today, Misty, thank you so much for being here and talking about borderline personality disorder, the myths, and what treatment looks like, and just kind of how to access care. So we really appreciate this conversation and you being here with us.
Well, thank you for having me. I adore Riley, and I feel so privileged to have known you and worked with you these past few years.
Thanks for listening to the Be Well Collective. If you have any ideas for future episodes or questions, please email bewellpodcast@aruplab.com. If you liked what you heard here, rate and subscribe for more. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. ARUP Laboratory and the Be Well Collective do not assume responsibility or liability for the actions, decisions, choices, or opinions of the individual listener. The content shared should not be used as a substitute for diagnosis, treatment, or medical guidance. Always consult with a qualified healthcare provider before making any changes to your care plan. Listening to this podcast does not create a provider-patient relationship. Use your discretion and take responsibility for your own health decisions. This show is produced by Riley Speth and Sara Hillring. Today's episode was audio engineered by Riley Owen.